Hello, sir.
Good evening, sir. Can you hear me?
Yes, sir. Good
Oh,
evening.
you've taken a very long holiday from us.
Yes, yes,
Must have enjoyed your holidays, though.
yes, yes. Really. So you're continuing. Of course, your busy schedule. I can see.
Yeah.
Very
And,
nice.
but this is the only time we can do. Once the lockdown is lifted up, I think many of us will not have enough time.
Correct, correct, correct.
We can start, sir. We are ready. We
Oh
have
yes.
more than 100 people already.
Okay, sir. Yeah. So good evening, everyone. We have seen a lot about microsurgery in the role of microvascular reconstructive surgery. But as I keep telling in all the techniques of reconstruction, especially of the thumb, I said replantation is the first and best option for reconstruction. And that is what we're going to see about today, replantation and the process of revascularization. We'll see what that is. So the agenda for today is, as we know, the replantation and revascularization. I'm going to deal with it under certain headings to make it simple and make it more understandable. The definition, the indications, the preparation, the procedure, and the follow-up. These are the basic things. And as we go on, we'll keep dividing into subtopics so that we can understand it as a whole. And of course, the quiz question of the day. Now, the definition of replantation is reattachment of a completely amputated part of the body by re-establishing the vascularity. So that is replantation, like you can see in this picture. Revascularization is another term, re-establishing the vascularity of a part of the body that has been rendered non-viable, though only partially severed. Now, in this sort of amputation, some amount of skin may be attached or some amount of tendons may be attached. Whatever it is not completely amputated, but it is not viable. So it has to be made viable by the same procedure that we're going to use for replantation. The only problem in revascularization is the cold ischemia time. We will not be able to preserve it properly. So the warm ischemia time is longer in patients who have had a partial amputation. We will see what this cold ischemia and warm ischemia is as we go along. So what are the parts of the body that can be replanted? It is only up to the imagination. Any part of the body that has a good artery and a good vein can be replanted. The foot can be replanted. This was done by my colleague and dear friend Dr. Jagan Mohan. And this is a replantation of the foot. Now, as far as the lower limb is concerned, usually we do not think much about replantation because good processes are available. But it is always good if the patient is able to get back his own foot and walk on that foot because he will have a nice sensate foot. And this patient had a very good result. The penis can be replanted. This was actually a mentally unstable patient who actually cut off his penis. This also can be replanted. It is quite a simple procedure because it's only the artery and the veins that have to be anastomosed and the soft tissues that have to be attached. This is a scalp replantation, picture courtesy Ganga Hospital, Coimbatore. Now, a scalp replantation. The good thing about this is this patient has only one chance at having hair-bearing skin, and that is with a replantation, and that has been done. You can see the excellent result that has been obtained. She's able to grow hair. If that had not been done, there is no other option except wearing a wig for this girl. Now, this is a replantation of the toe. The question may arise, why should you replant the toes? This was a 12-year-old boy for whom we did a replantation of the big toe alone. The second toe was crushed and avulsed. So this was the result. Now, the question is whether we need to replant or not. That's a very big question. And that we will go along, we will see as we go along in this discussion. The first replantation was done of the arm on May 23rd, 1962 at Massachusetts General Hospital for a 12-year-old boy who had an amputation by Malt. Malt and Mekan, Komatsu and Susumu Tamae did the first digital replant on January 7th, 1965. So after that, it has been the procedure of replantation has been growing by strides, and more innovations, the better anesthesia, the better resuscitation, all these have added to the good results. So at the outset, let us establish this basic concept that the aim of replantation surgery is not only to attach the hand or whatever part, the part must start functioning. Form and function are both a part of the aims of this particular procedure of replantation. Now, we will discuss this replantation. As I said, we will break it up into smaller topics. We'll first learn about the basics of ischemia and reperfusion. That is important. What happens when the part is amputated? What happens to the distal tissues? How long can they withstand the ischemia? This is very important to the understanding. And what happens when I establish an anastomosis and allow the blood to flow in? What happens? Is there any change that occurs? Yes, there is a big change that occurs. Then we'll talk about the basics of preservation, and then we'll talk about the sequence as the patient enters the hospital, the triage, the indications and contraindications that are already established, then making a decision whether we are going to replant or not. Then, once we have made a decision to replant, the sequence of surgery, the different steps that we'll be following, then the dressings that should be done, then the post-operative monitoring, then the follow-up. This is very important. The entire work of the plastic surgeon or hand surgeon or replantation surgeon begins with the replantation. The surgery is not over, the procedure is not over. Then assessing the outcome, we need to assess, we need to evaluate the results. And a very important aspect, dealing with failure. This can occur, it has occurred to everyone, it will occur. How to deal with this failure, we'll see that also. And we shall also we shall see special scenarios about amputation, replantation of thumb, replantation of multiple digits on the same hand, replantation of both hands at the same time, replantation of proximal level at the level of the arm or at the shoulder, replantation at the distal level. How does it differ from the other replants? Then ring avulsion replants, typical avulsion replants, how do they differ from the other replantation? Now, we'll go into the pathophysiology of ischemia. We all know that different tissues react differently to periods of ischemia. For instance, muscle, when there is ischemia, within 2 hours, irreversible changes will start in the muscle. Whereas the skin is more resistant to ischemia, and if stored properly, it can be stored for even up to a month with no loss of viability of the cells. So, in this situation, we need to understand the different parts of the amputated hand. They react differently to ischemia. Now, what is the problem with ischemia? How does it going to affect the results or replantation? Now, ischemia causes tissue hypoxia, and when there is a tissue hypoxia, there is a change from aerobic to anaerobic metabolism. When anaerobic metabolism starts, there is a buildup of lactic acid in the tissues, which leads to acidity and reduction of the intracellular pH. Also, the supply of adenosine triphosphate is diminished and intracellular calcium is increased. Now, two important mediators are released, phospholipase A2 and lysozymes. What do these two do? They cause tissue necrosis by the various cascade of events that occur. Now, restoration of blood flow to an ischemic organ is essential to prevent the irreversible cellular injury. This is basic. But reperfusion may augment the tissue injury. This is the paradox. The tissues were crying for blood, they were crying for oxygen. Once you get it going, they react differently. It's like you don't get water in your house for a long time. So you have adjusted and made some modification of the pipes. Now, when the water comes, you're not able to receive it. That's how I put that analogy to understand it better. Now, how does that happen? Now, the ischemia causes direct cell damage and produces inflammatory mediators, and it can also cause systemic effects. Once you get the blood flowing into the amputated hand or part again, there may be a systemic effects like decreased level of consciousness, jaundice, cardiac arrhythmias, myoglobinuria, and multi-failure organs. What are the mediators of this? How does it actually occur? There are different chemicals that are known to cause this problem: arachidonic acid metabolites, cytokines, chemokines, and activated complement system. But the basic the basic offending chemicals are the reactive oxygen species, what we used to call as the oxygen radical, superoxide. So these, the complement system and the leukocytes. The leukocytes come in great numbers and they sometimes cause a mechanical obstruction. And activated leukocytes release substances called proteases and elastases, which lead to increased microvascular permeability, edema, and thrombosis. So, the amputated part you carefully put back, and then you allow the blood to flow inside, and then you find, even though the blood is flowing inside, it is not picking up warmth, it is not able to survive, it dies ultimately, even though your anastomosis has been good, because this reperfusion injury that has occurred. So, how do we prevent it or attenuate it? You can prevent this reperfusion injury, or you can attenuate it. Now, there are different ways of preventing this injury. One is the ischemic preconditioning, that is, increases the cellular adenosine production. The second is antioxidant therapy, especially human recombinant superoxide dismutase. Third is anti-complement therapy. This complement system is what is one of the major factors that causes the breakdown of the permeability of the blood cells and leads to thrombosis. Anti-complement therapy, especially C3 convertase inhibitor, and anti-leukocyte therapy, like aspirin-triggered lipoxins. Now, these are drugs and techniques that can be used for reducing or preventing the reperfusion injury. But there are some strategies to attenuate, to reduce it. First is controlled graded reperfusion, sudden release. For instance, if you're doing a bilateral hand replant, suddenly when both sides the clamps are released, there is going to be a sudden storm of metabolites, toxic metabolites released into the general circulation. This may cause a problem. So you need to think of a controlled graded reperfusion. Second is hypothermia, cold. The temperature must be ambient. Warming will make it worse. Intra-arterial flushing. If the time is going to be more, you can do an intra-arterial flushing to get the metabolites going in and preventing this buildup of toxic metabolites within the hand. Good hydration is very important, something we can do at our level. We need to maintain the hydration of the patient. And most importantly, a good venous outflow. We'll see that as we go along. So this is to show, for instance, if the amputation level of the arm, I told you that the distal part can go for a reperfusion. So we can put in a vascular keeper shunt. Put in a shunt, allow the blood to go inside and perfuse the tissues while you're getting the replantation ready. Now we'll go to the basics of preservation. Once the amputation has occurred, we need to preserve it properly so that it will be possible to do a replantation of that part. If it has not been preserved and it is dead by the time it is brought to the hospital, you cannot do a replantation, obviously. So the preservation is one of the most important steps which is going to decide whether the replantation can be done or not. So this is the basic steps. These are the basic steps. First, wash the amputated part in running water. Second, dry the part with a clean cloth. Then, if possible, wrap the part in a saline moistened gauze. If it is not possible, it doesn't matter. Third, put the part in a clean plastic bag. Then, seal that plastic bag. Put this sealed bag in ice. Do not allow the ice. If the ice melts, the water may seep inside. This should not happen, so the bag should be sealed. And this sealed bag should be put in ice and transported to the nearest hospital where the replantation can be done. When you do this, you are starting what is known as the cold ischemia time. Cold ischemia time is the time between the chilling of the part after the blood supply has been cut off and the time it is warmed by having its blood supply restored. So it is on ice. It is at 4 degrees Celsius. This is the cold ischemia temperature, and this amount of time duration is called the cold ischemia time. Warm ischemia time, it is the time the part remains at room temperature after its blood supply has been cut off till the time it is either chilled or reconnected to blood supply. We must remember here that the 1 hour of warm ischemia is equal to 4 to 6 hours of cold ischemia. So, if the time which is going to be taken to transport the patient is more, it is better to keep it under cold ischemia and reduce the warm ischemia time as far as possible. So, how do the tissues react in warm ischemia time, cold ischemia time? The bone, tendon, and skin, as we have seen, are more resilient to drying up or hypoxia. So warm ischemia can be up to even 8 to 10 hours. You can possibly replant it even after 10 hours even if it has not been preserved. But the muscle can withstand warm ischemia only for 4 hours. And the digits are even more resistant. They can withstand warm ischemia even for 12 hours. Whereas with cold ischemia, the bone, tendon, and skin can be preserved for up to 24 hours. The muscle can be preserved up to 12 hours maximum. The digits can be preserved up to 24 hours again. Now, the thing is, even though they are preserved, definitely some changes would have come in, and it is important to foresee these changes before we take them up for replantation. Now, the patient has had an amputation and the part has been preserved and is being brought to the replantation center. Now, what is a replantation center and how do we organize a replantation center? The first is you need equipment, an operating microscope, a surgical loop, other supportive surgical equipment, diathermy, tourniquet, all that. The instruments especially have to be a little more special. You need regular surgical instruments and specialized micro instruments. You need disposables like suture materials, micro suture materials, and then most important in any organization, the personnel. Now, who do we need? You need a good anesthetist. First, the anesthetist. The role of the anesthetist comes first in any surgical procedure. Next, the surgeon, then the nurse, then the theater assistant and worker. The role of every single person cannot be ignored in such a major procedure. And after that, after the replantation procedure, the role of the therapist is very important. As we said, it is not just form, we need to get back function also. Basically, you need only these things to do a replantation. A standard operation theater, a surgical loop is enough if it's going to be a little proximal or at the level of the wrist. But at the level of the finger, it is better if we have an operating microscope. Then basic bone surgical or bone fixation equipment, micro instruments, and micro suture materials. We have already seen when we talked about microvascular reconstructive surgery. We talked about the micro sutures and the micro clamps and the different micro instruments. So these are all essential for the once the patient has reached the hospital and entered the hospital, we do a triage. Now, the triage is not only for multiple patients coming in, for the same patient coming in, for a single patient, you decide which is the important injury. Usually, when a patient comes in with an amputated hand, everybody rushes to deal with that amputated hand. We always tend to forget less dramatic patient's life. That is more important. The amputated hand always seems very dramatic, but the patient's life is most important. So the general condition of the patient, we have to follow the ATLS protocol and make sure that the patient is comfortable. We need to rule out life-threatening injuries. before we go further into the treatment of the amputated part. Then again look for other major injuries. For example, a fracture of the femur, it might be missed. This must also be seen. I keep saying again and again, general condition of the patient must be ascertained before we go into the limb problem. Look for the problem in the other limb, other upper limb. If it is an amputation of the hand, the other hand. Other injuries to the amputated limb. The same limb also can have proximal amputations. I'm sorry, proximal injuries, major injuries. That should also be taken care of. And lastly, then you look at the amputated part. Sometimes we call this as the amputate. Now, before we go and make a decision, let us see what are the prescribed indications and contraindications for a replantation. Because this is sometimes very difficult to decide. We'll go first by the textbook and then go by the basic problems. The indications for replantation are multiple digital amputations, you must replant. Thumb amputations, replant. Whole hand, definitely it must be replanted. Transmetacarpal partial hand amputations, any amputated part in the child, or single digit amputation distal to the flexor distal superficialis insertion, you replant. Why it says single digit amputation distal to the FDS insertion, that means there is only a single tendon to repair and the functional result is good. I keep saying again and again, function is most important. If the amputation is proximal to the insertion of the FDS, it is a zone 2 injury. As you know, there are two tendons. The result may not be very good, and so we have to, it is a relative contraindication, relative indication rather. Now, there are different contraindications. Do not do a replantation if there is a concomitant life-threatening injury. If you have a good anesthesia team, if you've got a good backup, if you've got a good ICU backup, you can try it, but it is very important to remember, keep remembering all the time that the life of the patient is more important than the replantation. Systemic illnesses like small vessel disease, poor anesthesia risk, mentally unstable patients. I told you we had a patient who had amputated his own penis. We put it back, we replanted it. It survived beautifully for about a week. And then patient went to the toilet. He had a blade. He cut off his own, the replanted penis. All our work went because we had not decided, we had not chosen the patient. And this patient was mentally unstable. And as I said, the single finger proximal to the flexor distal superficialis insertion in adults is a relative contraindication. If the patient insists, you can always do it, but we must explain to them the possible results. Multiple segmental injuries in the amputated part, severe crushing, avulsion, contamination, all these are relative contra. There is no such thing as an absolute contra except the threat to life. Prolonged warm ischemia time, ribbon sign, red line sign. These are signs that are seen on the amputated part where the injury on the vessel. Now, in the amputated part, the vessel must be intact. Proximally, if there is no vessel, it doesn't matter. You can always put in a vein graft, you can get a vessel from somewhere else. But in the distal part, in the amputated part, if the vessel is not there, there is absolutely no point in doing a replantation. It is not possible, it will not work. Then, most index finger amputations. That is also a little controversial. If it's a single index finger amputation, people believe that it's only a relative indication and not necessary to do a replantation, or if the patient can insist on it, you can do it. Like, as I said, the life of the patient is most important. Now, okay, now we have seen the indications and contraindications. Now we'll have to see, we have to make a decision. And indication and contraindications are there in the textbook. But here, I am having a live patient, I am having a good, healthy patient, and I need to make a decision. The books help me to a certain extent, but there are certain other factors that come into play when I'm making a decision. Three important things: the condition of the patient, the condition of the amputated part, and the condition of the proximal stump. As far as the patient is concerned, general condition of the patient must be good. If it is not good, there is no question at all. Patient will not come in here, patient is going to be resuscitated. Physical parameters, hemoglobin, all that, and anesthesia, fitness, psychological makeup, and Once we have decided that the patient is good, we can think about a replantation. Immediately, we need to get X-rays done to show the stump and the amputated part in the same X-ray with a little distance apart. Second, now we have to look at the amputated part. The condition of the amputated part must be seen, the time on preservation. What was the warm ischemia time? What is the cold ischemia time? How has the part been preserved? Has it been preserved properly? If it has been preserved properly, you need to physically look at the amputated part to see whether the red line sign is present on it or the ribbon sign is present on it. Then we need to see the nature of injury. How has the crush been? How has the avulsion? Is it an avulsion? Now we'll see that. Now, the nature of the injury, it could be a clean guillotine amputation, in which case there is no problem. We can go ahead with the replantation, provided the patient's general condition is good and the proximal stump is good. If it is a crush amputation, if it is an avulsion amputation, a crush amputation is by a bigger machine or a bigger injury, bigger force that can cause the amputation, or amputations with a loss of segment. Now look at this amputated part. You can obviously see that it has been crushed beyond. Now can you see that red line there on this finger? You can make out that the skin has been so badly crushed you cannot replant. But I've shown this picture just to show this red line over here. This is the red line sign or the ribbon sign which says that this vessel is injured. Anyway, we're not going to replant this. Now the question comes when there is a segmental loss or an avulsion. Now, this patient has presented, this young man, actually, 18-year-old man, he presented with an amputation like this of the left hand. And if you note here, this is the distal hand, this is the forearm. So now we need to take an X-ray to find out what is the condition. If you look at the X-ray, you'll find that the distal portion of the radius and ulna are not there, and the carpal bones are not there. The base of the metacarpals are not there. So that means there is a segmental loss. So now the question comes whether it can be replanted. We did go ahead with the replantation, and we arthrodesed this wrist now. And this was the result. You can make out the almost good function and is able to carry out these activities. So this is the function that you can expect. This is what we want. It's not just putting back the hand, we need to get back function. Now, what happens if there's an avulsion amputation? The problem with avulsion amputation is that the injury to the vessels is much more than what you can see. So unless you go in and explore the vessels and explore to see the nature of the vessels, we cannot get a good result, and not getting a good result is not an option at all. You need to get back function. Now look at this patient who has an avulsion of all the tendons. It is the right hand of a 35-year-old laborer. Now the question was, should we replant this or not? So what we decided was we would go ahead and replant it. Then we will go ahead with reconstruction of the animation, because we're going to remove all these. So now we have removed all that. We've got only the median nerve and the ulnar nerve for sensibility to be provided. No tendons are there. So we thought we will reconstruct later and replanted it, deployed the vessel well, and then this was the result at the end of 10 days. After 2 weeks, the graft settled well. Now the graft has settled well. Now this was a success. So now it led to the question of deciding to do or not do a replantation when there's an amputation. To do or not to do, we have decided that the answer is the Nike principle. You know the Nike ad. It says just do it. It's almost like as if they're telling us, just do it. If it fails, you can always do the reconstruction. But once in, once in a chance, lifetime, once in a lifetime chance for that amputated part to be put back. And that is if you do it. If you don't do it, even that chance is lost. So we need to look at certain prognostic indicators to find out whether it is worth putting back. The first is multiple cutaneous hemorrhage. I just showed you hemorrhages along the line of the vessel. that is caused by the traction on the vessel. The ribbon sign is also a stretch and torsion of the neurovascular bundle. When you look at it, you can see that it is rotated and crushed. In that situation, it is not possible to put it back, and it is not worth putting it back. The third thing, we have seen the patient, we have decided he is fit for the procedure. We have seen the amputated part, we have seen that it is fit for the procedure, and we decided we are going to do it anyway. But the third important thing is to see the stump. The stump must also be good. Only if the proximal stump is good, you can put that amputated part back. So, condition of the proximal stump is very important. If there is extensive loss of tissues that can occur sometimes in extensive road traffic accidents or machine injuries, in that situation, even then, because the amputated part is good, you can always do what is known as a heterotopic replantation. That is, the good amputated part, you put it back somewhere else in the body. When this proximal stump has been reconstructed or made better, or the situation is conducive to receiving the amputated part, you can always bring it back. Remember, when we talked about Marco Godina, he was the first person to do a heterotopic replantation. He replanted the hand in the axilla, then brought it back here to the hand. The second is it can be put in the opposite hand. For instance, if there has been an amputation of both hands and one hand is not good, whereas the stump and part must be good. You can always do a cross hand transplantation, replantation, or you can put it back in the leg, as this picture became viral a few years ago when they did a heterotopic replantation. So this also should be thought of. So now we have taken a decision that we're going to replant. We have seen the patient, we have seen the amputated part, and we have seen the stump and decided it is good. Or sometimes we come across situations where replantation is not possible. Even then, you have to think out of the box whether it is possible to use the tissues that are present there to somehow do some closure of the stump or help this patient. A reconstruction can always be done. It can be done tomorrow, next week, next year. But this situation where the amputated part is there, viable tissues are there, you're not able to do a replantation for various reasons. Is it possible to use the tissues? Just see this example of a young school teacher who had an amputation of the left hand. Now, because of the avulsion, we decided against replantation. But if you look at the stump, she had a small stump, bones on the forearm. The elbow is here. And if you want to close this stump as we would normally do, we may have to shorten this bone. Only then you can close the stump. But if you shorten this bone, the amount of elbow available will be lost. So there we decided, now look at this picture shows we may have to shorten till here, till the level of the elbow. You have to disarticulate the elbow to be able to close the stump. So we thought about this and planned to use the skin from the palm and this amount of skin over here after ascertaining the viability to cover this stump. And that is what we did. So we were able to preserve the elbow joint for this lady so that she would have a good elbow and the prosthesis can be fitted easier. This is called opportunistic surgery or spare part surgery. You're using the spare part from the amputated part, which is not replantable. Now, we have come to the main surgical sequence. Decision has been made to replant. Clear, we are clear in that. What next? So the next part is going to be patient is being resuscitated now. Patient is getting ready for the anesthesia and the major surgery. Right now, what the surgical team has to do is the dissection of the amputated part, sometimes known as bench dissection. We need to look at the amputated part and then make sure we get all the structures ready so that the replantation can be carried out. So the bench dissection of the amputated part is done. The whole step of bench dissection is based upon identifying the structures and tagging them. One, we need to make the correct incisions so that we can expose the vessels, the veins, the nerve, the tendon, everything. then we need to identify the veins. The veins always come first, because when you handle the amputated part, the only way of identifying the veins is by the little blood that remains inside them. The arteries you can identify by their tough structure and anatomical position, but veins are not like that. They can be anywhere, they can be an alteration. So the only way you can identify is by the blood. If you manipulate the hand or amputated part and try to dissect the other structures, by the time you look for the vein, there is the blood has all been emptied out. You cannot identify the veins. So the veins are identified first, then the arteries identified, then the nerves are identified and tagged. You can put in a stitch to mark it. Then the tendons, the flexor and extensor are identified, and the bone is next shortened. You can shorten the bone. Shortening of the bone is an important part of procedure, because shortening of the bone will allow a good vascular anastomosis without tension, and it will also allow a nerve approximation without tension. And if you're going to put in a plate and screw or a K wire, you can put in that part. I can put in a K wire into the distal amputated part. When I bring it to the stump, I just have to drive the wire in. So these are the steps to be done in the bench dissection. Now the patient has come into the OT and anesthesia is given. The tourniquet is applied. The debridement and irrigation of the amputated part and proximal stump are performed, and identification and tagging of structures is done here also. It must be catalogued. What is here, what is not here, and everything must be identified. Some people put in a small tag to show what it is, because once you bring in the amputated part and fix it here, it becomes a very confusing thing. It is important to have a good tagging. Then shortening of bone if necessary on the stump. Usually this is not done, because if the replant fails, you don't want a shorter stump. So usually it is done distally, but in some situations it may have to be done proximally also. Now, once the patient comes in, we need to do the fixation. Now, this is the sequence. First, the bone fixation with K-wire or whatever. We'll see what are the different types of bone fixation. Then we have to do the extensor tendon repair. Then the flexor tendon repair. Then the nerve repair. Then venous anastomosis, arterial anastomosis, and skin cover. This is the sequence, and we will see the sequence as we go along. As I said, identification of the veins is important. We need to raise very thin skin flaps on the dorsum. Sometimes we forget the anatomy of the veins on the dorsum of the hand and the finger. It is present in the subcutaneous fat that is present in the dorsal skin. So here you can go either above, that is, you raise dermal flaps and look at the veins from the top, or you raise the entire flap and look at the vein from underneath, because it is present in the subcutaneous fat. The volar veins are more superficial. There are volar veins that can also be used for venous anastomosis and replantation. Now this shows, as I was telling you, the veins are present in the subcutaneous tissue. You can raise the skin flaps at this level. Now the skin flaps can be a single incision on the dorsum of the skin of the finger or the hand to raise two flaps, or you can make two mid-lateral incisions on the finger to see the arteries, or you can make a mid-volar incision and open it up like that to see the arteries, veins, tendons, etc. Here, this is what I was telling you. You can identify the veins from underneath, or you can identify the veins from the top. Actually, this identify the veins from the top was described by the Ludhiana people who have done a lot of replantation, and they call it the Ludhiana technique. And identifying it from below is called the Louisville technique, which is a center in US. Then the tendons are, you can see the tendons here. These are identified and tagged. You can see the flexor tendon here. You can see the digital arteries and the nerves. So all these are identified. Then the bone is dissected or shortened. Remember, you have got very important structures all around the bone. We can use a technique called the hole in the lint. You take a lint, moisten it, wet lint, make a hole in it and put it over the bone to protect all the structures, then work on the bone to shorten the bone or fix the bone. Now, identification of the vessels, the veins, we need to identify at least two veins. The correlation exists between the number of veins repaired and the success. the guideline is the cross-sectional area of veins that are repaired must be twice that of the artery. That's the basic guideline. And if the artery is big, the more number of veins you must do the anastomosis if the veins are small. Now, should we identify the veins now, or should can we identify the veins after we do the artery? This is a very common problem, common question that runs in our mind. If you're not able to identify the veins, distally you can usually identify the veins, but proximally sometimes the veins are collapsed, you may not be able to identify. We must remember now it is under tunicate, and when it is under tunicate, it is better to identify it. Once you got the artery running, it is very difficult to identify the veins, especially proximally, because there is going to be a soiling of the blood. And there is another reason why you should not release the artery first, because when you release the artery first, you're going to cause a thrombosis that can occur within the microvasculature of the amputated part. Now, we can radically debride because we can shorten the bone significantly, as I told you. Bone shortening is very important. If you do not shorten the bone adequately, it can be disastrous to the replanted hand or part. Many times it avoids the need for vein graft, and your nerve repair can also be good. Now, I told you, distally you need to get an artery and a vein. There is no other option. You have to get an artery and vein. If you don't get an artery and a vein distally, then you cannot do the replant. Whereas proximally, it doesn't matter. What you need to identify it, you can go even more proximally. There are two choices. If you don't have the corresponding proximal artery or the proximal vein, you can either transpose it from the neighboring area. You can get it from the cross finger. From you can take it from the same finger. You can take the contralateral, the other side digital vessel artery, or you can put a vein graft, or you can take the artery from the thumb and put it for the from the index and put it for the thumb. You can borrow the artery from the proximal artery from the adjoining finger, or put a vein graft. Now, coming to fixation. The fixation of the bone is important because it is going to provide the stability. It should be quick, it should be stable, and it should cause the least amount of damage. The more time spent in trying to fix the bone will tell on the ischemia time. Now, the fixation can be either external fixation or internal fixation. There are some centers who, for a forearm replantation, they apply an external fixator and they put the part back and apply an external fixator. This is an excellent technique, but we are generally conversant with the internal fixation. Internal fixation can be done with K-wires, with plate and screw, and intraosseous wiring. Now, what is the intraosseous wiring? Where you put the wire between the two bones, or K wires. Just K wires are very simple, but they do have a problem in that they are not rigid fixation, and the healing may not be optimal. We'll see an example later as we go along. And intraosseous wirings are very quick. You just have to tighten the screw as you put them on. Now we come to the tendon repair. We have seen the arteries, we have seen the veins, we have only identified the artery and vein. We have not done the anastomosis. Now we do the tendon repair. We had already identified the tendons. First, the extensor tendon repair is done, and then the flexor tendon repair. Why extensor first? The only thing is, it is easier to identify it's easier to suture the extensor tendons when it's not under tension. Whereas the flexor tendons, if you suture them first, it may be difficult to suture the extensor tendons, especially when you put in K wires. Then all tendons are to be repaired. Usually horizontal mattress suture is used for the extensor tendon repair. For the flexor tendon, again, all tendons are to be repaired. Our aim is to get back function. We need to repair it like we would do a tendon repair. And a modified Kessler-Mason sutures are applied for the rounded tendons, and horizontal mattress sutures are used for the flat flexor tendons. Nerve repair next. Once you have done the tendon repair, we need to do the nerve repair. We, as beginners, we would want to jump into doing the vascular anastomosis. But remember, if it is at the level of the hand or at the level of the digit, there is no problem about ischemia time. I told you it can withstand ischemia for quite some time. But without a good nerve repair, without good sensation, function will not be achieved. So debridement of the nerve ends is very important, epidural suturing, and it must be done under magnification with 9O or 10O positive polyamide suture, and usually the need for nerve grafts are rare. Artery repair. As far as the artery repair is concerned, there are few steps. The first step is debridement, the second step is debridement, and the third step is debridement. You must have a good artery which is going to push blood into the amputated part. The entire success of this replantation is going to depend on this proximal artery that you're going to put there. And only when this artery is perfect, you can get a good result. And how do you know the artery debridement is adequate? You will have a good spurt of blood coming out from it, and next you will have a good rounded lumen. Now, if you cut the artery and let it wait over the time you are doing the surgery, some arteries will tend to collapse, or some arteries will tend to get occluded with some sort of fine silky material. Whereas a good artery, if it is really good, it will stay with a circular movement. Then we need to do the artery anastomosis. Right on. Yeah. Now the artery anastomosis is done. The suture size that you're going to use will depend on the area where you're going to do the replantation. For instance, if it is on the arm, you can use a 70 Prolene also. If it is on the forearm or wrist, 80 polyamide can be used. But if it's a digit or thumb, 10 polyamide or ethicon should be used. Vein repair. Now, I said artery repair first. Now I am saying vein repair. The sequence of doing this is not very important. Whether you do the vein first or whether you do the artery first is not important. But what is important is when you release the clamps. And we will talk about that. The vein repair is also done the same way. A good debridement of the vein ends is important. Vein anastomosis can be done. If there is any problem, if there is any tension on the anastomosis, we have to reconsider and do either a transposition or one of the techniques I said, you borrow from the next finger or you put a graft. And remember, more numbers of anastomosis should be done for the veins. And the suture size again depends on the area. If it is the arm, you need to use 8O. It is finer. We need to use a little finer material for the veins because they are thinner walled. And forearm wrist, you use 9O, and digit or thumb, we use 10O again. When to release the clamps? This is an important question. You have done the bone fixation, you have done the tendon repair, you have done the nerve repair, you have done the artery anastomosis, you have done the vein anastomosis. Now, can I release the clamps? Yes. Artery first, or should I do the artery first, release, and then do the vein anastomosis? I already told you this will not work because the blood that has gone into the circulation is just flowing out now because there is no venous outflow. In those situations, microthrombi will start developing within the microvasculature, and after that, even when you do a venous anastomosis, there is going to be a thrombosis, it will fail. What is best is complete everything. That is what I say is you complete the circuit and then release the clamp. What is the circuit? One artery and one or two veins. After this is done, if you release it, all the metabolites will go out through that. There will be no extra bleeding. There will be some extra bleeding because two veins are generally not enough, but it will serve to reduce the ischemia time. And once the circuit is complete, the clamp can be released. Ischemia time is not a great problem, and it's easy to repair tendons and nerves in a bloodless field. So the artery, the vein, whether you do the artery first or the vein first doesn't matter. But after you do both, only when both have been done, both anastomosis have been done, the clamp should be released. Now we come to the skin closure. We have released it. We have seen the nice pink flush that occurs on the tip, which is going to tell us that the circulation is adequate. Now, this pink flush should be monitored. It is not the end of the surgery because there are so many other factors that can go wrong. So we need to now go for a skin closure. Now, the problem with skin, even though it was a guillotine amputation, the problem now is edema would have set in. Once the edema sets in, it is difficult to close it because it becomes tight. When it becomes a tight closure, the veins that are just under the skin will get compressed, and that will compromise your result. So you cannot do that. And the vessels or the anastomotic site may be exposed in the wounds. That is the next problem. Now, there are two questions. Now, there is an exposure of the vessels. I am not able to close the skin. The replanted hand or finger is doing very well, but I'm not able to close the skin. Can I leave it open? There are chances it gets infected. There are chances that the vessel may get exposed, and after infection, it can get thrombosed. So these problems. So I've got two questions now. Question of what to do for skin closure, whether we need to do a flap or a graft, and the next important question is when should it be done now, or should we do it later? Now, skin cover for this sort of replanted parts can be done either primarily, primary skin cover, either in the form of a skin graft or a flap. The flap, if it is done, is preferable to do a microvascular flap. You can also do a pedicle flap, as I shall be showing you. A skin graft is also accepted. Even if it is on the exposed vessel, a skin graft is also accepted. Usually, we apply a thin skin graft which is unmeshed over the raw area to cover the vessel. Nothing will happen. The vessel is also a vascular structure. You can, according to the principles of skin grafting, you can put a skin graft on any vascularized structure. The second is, if you're not able to do it immediately, the skin graft or flap, you can do it as a delayed primary procedure after 10 days. When the replanted hand or part has settled well, the vascularity is well settled, you can do the skin cover now. It is a little safer option. The third is secondary cover. It is not ideal because the wounds have been left open for too long, the risk is too much, and it will hamper mobilization, which has to be started at the end of 3 weeks. As you know, function is our most important secondary ideal. Now look at this patient who has had an amputation, complete degloving of the index finger, and thumb has been amputated. So we put this, we replanted this, and at the end of 10 days, the dorsal skin necrosed. So we have debrided that, and there is a raw area. So we have planned for a flap cover. We have taken, now the thumb has survived, and that is what we felt was most important. The index finger had also survived but had a large raw area. So we decided to amputate the index finger and give a flap. Oh, we have not, yeah, this patient we did not amputate. Yeah, the skin has also survived and the flap has also survived. So this was a case of delayed primary skin cover. It is also permissible, which will also give good results. Now, the dressings that are to be applied. Non-adherent layers should be kept on the suture line. Bulky dressings, no compression. This should always be on the back of our mind. There should be no compression anywhere along the replanted path. The POP. Now, this is another question that comes to our mind. Should we give a POP? Absolutely. There is no question. Now, should we give a POP slab or should we give a cast? Now, the problem of POP slab is that sometimes it is not very effective in the sense that what we want is absolute hand elevation. Above elbow cast is what we use even if it is a finger replant. We use an above elbow cast and keep the hand in a comfortable position after applying a nice bulky dressing. Above elbow cast with the elbow in 90 degrees, forearm in mid prone position, and fingers in comfortable position so that we can keep monitoring the tips of the fingers. At the same time, it is very difficult when you give a 90-degree elbow cast to put the hand down. So they always keep it elevated. It's very comfortable position also. The edema will also come down. We need to keep them warm and in bed for 5 days. Adequate hydration. We always prescribe for adult patients 5 pints of fluids, whether it is sweating, whether it is cold, whatever, 5 pints every day, and extra fluid if there is according to the urine output. And our protocol is no dressing change till discharge. If the skin cover is not been given, at the end of 10 days, we do a dressing change and give a skin cover, like I told you, the delayed primary skin cover, and then we discharge after that. Now, the role of drugs and supportive therapy. The most important thing is the flushing solution. While you're doing the surgery, you need to keep the tissues moist. And once the vessel is open and the anastomosis is going to be done, you need to use only heparin. The second solution you use is xylocaine solution, which is 1% xylocaine solution. Now, 1% xylocaine solution can be used, but we should remember that xylocaine should not be used when the vessel is open. The xylocaine should not go inside the vessel because it causes a lot of spasm inside and causes intimal damage. So when the vessel is open, we use only the flushing solution, which is made from 5,000 units of heparin and in 500 ml of normal saline, and xylocaine solution only after it has been closed. The role of papaverine, low molecular weight heparin, and dextran 40 is dependent on the institution. Now, post-operative instructions, hand elevation, the IV fluids, hydration must be maintained, urine output must be maintained, antibiotics, analgesics, and most importantly, monitoring. So, how do we monitor? Clinical monitoring is the best method, uh, as there are different sensors and probes to monitor, but clinical monitoring is the best. The color, the capillary refill, the temperature, bleeding, turgor, and if it is the finger replantation, you can use the pulse oximeter. If there is any doubt about the viability, if you feel it is becoming slightly colder, the best step is to do a re-exploration. So, what are the problems that can occur? If there is a venous insufficiency, the color will be blue, the turgor, it will be engorged, bliss capillary refill, low temperature, it will be colder than the adjoining fingers or adjoining hand, but the pulse will be intact. Arterial insufficiency, the color will be pale, it will be flaccid, and the capillary fill will be slow. The temperature again will be cold, and the pulse will be absent. Now, special scenarios in replantation. Now, I've got another 10 minutes. Can I continue, sir?
Oh, you have all the time, sir. You can
Okay,
go for as
thank
long
you.
as you can.
Another 10 minutes. Now,
Take
special
your time. Yeah.
yeah, thank you, sir. Now, special scenarios in replantation. There are now the same principles that we talked about all along will be used in all these special scenarios, but each has got a particular unique point that we need to remember when you're doing that. And these are situations that we come across quite often in a high output center. First is the thumb. The thumb must be replanted unless very grossly crushed. It must be replanted. An attempt must be made. And the position of the thumb in fixation should be correct. It must be kept in palmar abduction or the glass holding position of the thumb so that even if it becomes stiff, it will be useful. So this is a guillotine amputation which can be replanted and you can get a good result. As I told you, the function is also important. You can get a good result. Now, even if it is avulsed, we saw a guillotine amputation, even if it has been an avulsion of the thumb, if still it is worth trying it because you need to get back, especially in the right hand. You have to think about, you must do it. As I said, just do it. Nike principle of just do it. So the replantation has been done and the thumb has survived. The basic function, you would have noted that the FPL has been avulsed. FPL has been avulsed, the IP joint movement is lost, but the basic CMC joint is there, he will have good function. If there are multiple digit amputations, there are different questions that have come to our mind. Which fingers can we replant? Do we replant all the fingers or do we replant some fingers? In that situation, you think about which are the important things. If it is possible, do a replant of all fingers. If there is a shortage of time or the shortage of personnel, then you can do the replantation of the most important fingers and the fingers that are not crushed. Priority fingers, the thumb obviously, index finger, mid finger, that is the priority in order. Then, do we need to do a finger first or part first technique? There are two different techniques of doing multiple digit replantations. It is called the finger first technique or part first technique. We'll see what that is. If time is not a constraint, you can do the part first technique. If time is a constraint, do the finger first technique. What is this part first and finger first? Now, the finger first technique is finish all the sequence described above for replantation for each finger. First do the index finger, then do the middle finger, finish the middle finger, then do the ring finger, then lastly do the little finger. So this is called the finger first technique. So the priority thumb, index, mid, ring, and little fingers in this order. Whereas the part first technique is finish the bone fixation on all the fingers, then do the extensor tendon repair on all the fingers, then the flexor tendon repair on all the fingers, then the artery and vein on all the fingers. So the entire procedure will get over at the same time. So here, this can be done when ischemia is not a problem. Ischemia time is not a problem. Whereas if ischemia time is a problem, we need to get in as many viable fingers as possible. So we do the finger first technique. So in this sort of multiple finger amputation. When you get a bilateral replant, the same sequence that you're going to do, but there are certain questions. Which side first? And can we do both sides together? Yes, definitely both sides replantation can be done together. Which side first? If one is more proximal, if you have to do only one after the other, you need to do the side which has got a more proximal amputation, because the ischemia time would be more. The tissues will be able to withstand less, because there is a possibility of having muscles in it. But even if you do both replants together, please remember one point: do not release the clamps on both sides at the same time, because it will cause a massive influx of toxic metabolites and lead to a very severe problem in the patient. So monitoring of the patient, the hydration status are very important. So in a bilateral replantation, if you have got enough personnel and teams and you can coordinate the teams, you can do both together. Then the next special type of amputation is a proximal amputation. These are called major replantation. That is at the level of the arm or at the level of the shoulder. Now, these are very important because there's a lot of muscle in the amputated part. When we talked about finger, when we talked about hand, there is not much of muscle inside. So they can withstand ischemia for a longer period. Whereas in these major replantation, ischemia time is very important and the replantation must be done, and the arterial input must be going within 6 hours following injury. Here, the sequence that we have discussed all along, first the bone fixation, then the tendon, then the nerve, then the artery, then the vein, this sequence will change because we need to combat the ischemia time. You can do the artery and vein first and then do the fixation. It's a little difficult, but that is what will get the survival of the hand. Then the fixation of the skeleton can be done. But we need to remember, even if you have done it as fast as possible, there is a possibility of a compartment syndrome developing in the forearm. So we need to do a fasciotomy also in anticipation of the problem that is going to develop, because the muscles would have gone in for some amount of reversible damage. Even though the reversible damage can be corrected if the replantation is done in 6 hours, there are going to be some changes which will be noted. Distal amputations. Distal amp can be at the level of the palm, where you can get good results. The And then as you go more and more distal, it is the thinness of the vessel wall and not the diameter which is the problem. So here, when you go to tip replants, that is a problem. The vessels are still visible, but they are very thin walled. So the replantation technique also will differ. We need to use finer suture materials. There are different classifications for the levels of amputation, starting from Allen, Hiras, Ishikawa, and Tamai. But the most commonly used classification of the tip replantation is the Allen classification, where the type 1 involves the pulp, type 2 involves the pulp and nail bed, type 3 involves the distal phalanx fracture with the pulp and nail bed, and type 4 the lunula, distal phalanx fracture, pulp and nail bed. So you can get good results because there is no question of any tendon or any movement. It is only the skin that must survive. Here, the veins may be a problem. Volar veins can be identified. If veins are not identified, we can allow different techniques like allowing it to bleed with heparin, so that in 3 or 5 days, the venous collaterals develop and it can be established. Then the last type of special characteristic, special replant is the ring avulsion amputation. Now, here we need to remember that usually the amputation of skin is at the level of the proximal phalanx, but the amputation of the skeleton is at a different level. It is at the level of the distal interphalangeal joint or the middle phalanx neck. And because of the avulsion nature, it is difficult to do the anastomosis of the same distal vessel. Usually we need to do a cross arterial anastomosis from the other side, that is from the contralateral side of the finger, and vein grafts may be needed for the fingers. Now this is an total avulsion amputation, and replantation has been done. Now ancillary procedures, skin grafting or flap cover, we have already seen. Skeletal stabilization procedures, joint release if there is weakness. Now, here, this was a distal forearm replant. We could not get the orthopedic team at that time. So, what we did was we did a K wire fixation and stabilized the fracture. You can see the level of amputation and see the K wire fixation. This will definitely not heal. However, the replanted hand survived. So after that, patient went for a plate and screw fixation. We did the plate and screw fixation afterwards as an elective procedure to bring back good amount of function. Then we come to the next part called failure. Never let success. This is a major procedure. Once you get a success, it tends to get to your head. But you should never let success get to your head. And at the same time, most important, never let failure get to your heart. Don't get depressed. See what is next. Failure is success if you learn from it. Always learn from it. It is not a failure. What would be the reasons for failure? Poor choice of indications. We need to retrospect. We need to introspect rather and see what is the reason for the failure and avoid it the next time. That's all. Nature of injury could have been avulsion, could have been an improper preservation. So the problem has been with us in selecting the patient. And technical reasons also could be a reason. Once there is a failure, you can't just sit with your head in your hands like that patient, that picture that we saw. We need to see what next. First, correct the problem. Either do a revision amputation or give a flap cover to preserve the remaining stump if it can be made functional, or do the next step of reconstruction as in a thumb. If your thumb replant has failed, it doesn't mean you can't go and do a toe transfer for reconstructing. If it is not possible, you can always do a prosthesis. Now, this is an amputation in the wood saw cutting machine. You can see one segment of the hand has been lost. We replanted it and we gave a groin flap for further reconstruction later on. Once we failed in the replant. Now we come to the important part, the function, the therapy. We remove the POP at 3 weeks. We start the therapy following POP removal. Wash with soap and water, scar massage, active mobilization is first started. Then we start the passive range of movements. Then gradually proceeding to passive range after removal of the K wires. As far as function assessment is concerned, there are different criteria. The Chen criteria, the Nakamura and Tamai scoring is there. So these you can use, or the DASH score. DASH score stands for disabilities of arm, shoulder, and hand. This outcome assessment can be used only for proximal replantations because it involves the functions of the elbow and the forearm and all that. But basically, what we need to see are what is the range of motion? Is he able to do his activities of daily living? What is the sensory criteria? Does he have any subjective symptoms like pain, numbness? How is the cosmesis? Does it look good? The amputated, the replanted part, does it look good? And most importantly, patient satisfaction. Patient satisfaction, sometimes the surgeon is not satisfied, patient is very satisfied. Sometimes we are satisfied, patient is not satisfied. That is an important factor because ultimately it is the patient's life, it is the patient's hand. So immediate satisfaction in a replantation is survival of the replant. But long-term satisfaction comes with quality of bone fixation, your quality of tendon repair, and a quality of nerve repair. So that was about replantation. We'll finish off with the quiz question of the day before we go to the discussions. What is the Kapana technique? Anybody?
Hello.
Yes.
Sir, it is a technique of massive bone graft. Hello.
Yes. Yes.
Massive allograft
Yes.
with a vascularized bone graft. Like in cases of if large bone losses of the lower limb, we put a massive avascular bone graft and cover it with and inside that we fill in a vascularized fibula.
Very good, very good. Excellent. Mosina, that is excellent. So that is what it is. Here you can make out the allograft, bone allograft. A slit has been made in it. And within that, the vascularized bone graft is going to be done. And the anastomosis will be done. So this is to ensure that the growth of this fibula may be too small for the big femur. But with this bone graft, once it starts growing, the growing bone can encompass that allograft and you can get a good thick bone. So that is the Kapana technique. Thank you. Now,
Solo 5
any questions? So the next session, what was that?
Sir, can I ask you questions if time is
Yes,
there?
madam.
Sir,
Yes.
about the vein dissection part which you mentioned, like
Yeah.
two techniques of raising subdermal and subcutaneous flaps.
Yes.
Which one will you prefer? Actually, practically we usually do subdermal technique in our institute, but practically 2 times we faced that there was skin necrosis over the survived replant part. So, is it advisable to go to a subcutaneous technique, especially in a major replant? Like major means the total hand replant, etc., not the fingers. And the second question is when we initially itself, when we dissect a part, do we need to select the veins and keep first itself and bust the veins which we are not going to use, or we see the backflow and then decide the veins? Because one vein we are doing, rest of the 3-4 veins which we need to do, do we leave open all the venous channels, or we select after seeing the reflow?
Yeah,
I mean
good.
the backflow.
Good. Now the first thing was whether you want to do a subcutaneous technique or you want to go under the vein.
Yes, sir.
No, the problem with doing only the dermal flaps, no? The first technique is raising dermal flaps. I usually use that technique for the dorsum of the finger. You use the dermal flaps and raise small flaps. See, what we are thinking of is about 1 or 2 centimeters, that's all. And it is easier to identify from the top. That is because I am conversant with that technique. Whereas you can lift it and see it from underneath also. That you can use it for the dorsum of the hand. There I would use the subcutaneous, that is you go under the fat and then identify the veins on the dorsum of the hand. Whereas on the finger, I would use the subdermal technique. The second question about veins. First is you select your veins. You need to select the vein. Supposing it is the hand, I would select one vein over here, usually the cephalic vein. Then I would select one vein on the dorsum, mid dorsum of the hand. And once usually don't get many veins on the ulnar side. So 2 veins on the dorsum of the hand, 1 vein on the radial aspect. If I do 3 veins, the other veins that I usually buzz them off. It is very difficult to see. There are two advantages of buzzing these veins. One is all the blood that is coming out through the artery and going through the circulation will all come through your anastomosis and keep your anastomosis patent. If you're going to leave some veins open, the blood is going to leak out through that, and that will reduce the pressure of the blood going through your anastomosis that you've already done. So that is also prone for a problem. What big veins that I can see that I am not planning to use for my anastomosis, I buzz. There may be some veins that I might think, oh, I might use this vein. I just put a soft clamp on that, then release the artery clamps, see the anastomosis. If the anastomosis is doing well, I'll buzz off that soft clamp vein. If it is not doing well, I'll use that vein also for anastomosis.
Thanks.